output. So main things you need to know here on this page. The intake and output should always be the same. Okay, whatever your patient's intake is, that should be the same as their output. Whatever goes in should come out. So average adult intake is 2,500 to 3,000 per day, meaning average output is the same, 2,500 to 3,000. That's a pretty large number if you ask me. Typically nursing homes, we're not going to be concerned with dehydration, with flagging our patients for dehydration until they're below maybe 1,500. Okay, so as long as you know that that's just an average, that's just an average number. Let's skip down to that key terminology. So you need to highlight, star, whatever you're going to do, that average intake and output. And then let's skip down to key terminology. You guys should know most of these terms. Edema is just swelling. So edema is excessive fluid in the body. If my patient has edema in their legs, what am I going to put on them?
Compression socks.
Compression socks, TED hose, anti-embolic stockings. Okay, all the same thing.
Can't you put an ice pack too? I swear I saw somewhere in this text that said you could put an ice pack on it.
Like for swelling, if it were like a bug bite or like an injury that was swollen, then yes, you could put an ice pack and that would help. But for like edema, no. If it's swelling from like a cardiac issue or something, no, that's not gonna help. What else would help besides TED hose when my patient has swelling? Let's say in their legs.
Compression socks.
Compression socks, TED hose.
Elevating the feet.
And elevating them, raising them up. Yep. Dehydration, that is just lack of sufficient fluid in the body. Diuresis, you guys have seen this term on a yes.
In my medical terminology class, the excessive urine output, they call it polyuria.
It's the same thing.
Oh, okay.
Polyuria also, yes. Okay. I think polyuria is a little bit more specific. Like polyuria is a certain amount.
Okay.
Many a urine.
Yeah. So diuresis is excessive urine output, and then diaphoresis. This is an important one you guys need to know. That is excessive perspiration, so sweating. So diaphoresis is sweating. So a lot of times when we're talking about somebody that is getting ready to faint, or if we're talking about a diabetic or something like that, we'll say the patient's diaphoretic, meaning they're just sweaty. They're kind of clammy feeling. Push fluids, you guys know that term. We are pushing fluids on anybody that is dehydrated or is that at risk of being dehydrated. Now, these are all the things that we can count as intake and output. In a nursing home, in most settings, even in the hospital, we're only going to be recording oral fluids and then urine. But depending on how critical that patient is, we can count all of this as INOs. So intakes can be oral fluids or IV fluids, TPN feedings, NG tubes, meds, any of that can be input. Again, in a nursing home, we're really just counting what they're drinking. And then types of output, of course, urine, and then vomit. Notice that the medical term for vomit is emesis. You guys need to know that if you don't. Emesis is vomit. Bloody drainage, loose stool, NG tube drainage, and even perspiration. If you've got a really very critical patient, we can even we can even measure their sweat for output. Okay.
How do you measure their sweat?
Just with like a, I don't really know.
Sweatometer.
Probably weight. You could probably do it by weight, like how wet something was, like if their clothing, something like that. Probably the
So that
same.
would be more like an approximate, not exact.
Especially if you have a diabetic patient that goes into low glucose.
Yeah.
I'm telling you, this is the worst sweats in the whole entire world.
Yeah, you could get it exact because like we measure urine exact from babies' diapers because we measure them dry and then with the urine, so we still get an exact.
Right.
So if you were to measure, somebody's
blanket.
clothing or blanket or something, you could get an exact perspiration measurement. Okay, so here's the math that we have to look at. If you're only going to remember one thing, I want you to know that 1 ounce equals 30 milliliters, okay? Star that one, highlight it, whatever. Remember that 1 ounce and 1 cc are the same thing. You guys already know that from measuring those graduates, that a cc and a milliliter are the same. And then 1 ounce is 30 milliliters, 1 cup is 8 ounces, and 1 pint is 2 cups. Okay, so biggest thing we need to know, 1 ounce is 30 milliliters. You cannot use a calculator on this state test, so we're not using them in class. You can use paper and pencil. Okay, you will have that available during your written test. Really, you just got to be able to kind of count it on your fingers. Just count by 30s on your fingers. Okay, so let's do a couple of them together, and then I'm going to let you guys practice them while I eat a cupcake. 1 cc is how many mils?
1.
Okay. 2 ounces is how many mils?
60.
60, good. A half ounce is how many mils?
15.
15, great. You guys work on that, and then we'll go over them together. The back page you don't need to do, that's just more math. That's just more practice if you want to go home and do it. Okay, but we're just going to do that first page. It's math, but it's easy math.
Why are you giving us math? This is not a math class, guy.
Yeah, the more you go up in your nursing degree, the more math you gotta know. Not that math. But she don't have no problem because she's good at math.
6 ounce bowl,
180.
3 8 ounce glasses,
700.
2 4 ounce glasses,
240.
and then a half a pint of milk.
420. Oh, half a, huh?
Half a pint is 480. It's 2 cups.
I skipped one because they were the same.
Oh,
12 and
I read
13 are
that
the
wrong.
same answer. And then 14.
Yeah.
I know, I was off for a minute. I was like, wait, maybe her book don't have that question.
Okay, is everybody good? You guys feel good with
It is
this?
240.
Yeah, just 240.
Because it's half a pint, which is 1 cup.
Yeah,
A half a pint is 1 cup, which is 8 ounces, which is,
Oh, yeah.
yeah, 240.
You had me thinking I was wrong.
I just trusted you too. I didn't even question
Half a
it.
pint,
Sometimes
not
I read
2
things
pints.
backwards.
I read it as 2 pints.
Yeah, what
So this is just more math,
I did. I
right?
read it as 2 pints instead of half.
Yeah. The back is
My
just
bad,
more
guys.
practice. If you guys want to do it, you can. If you don't, then don't. Okay,
I
it's just
did.
another practice thing.
I'm not doing all that percentage crap.
Okay, I do want to, we're going to go back to that first sheet that we were on. You guys are going to need your book now. If you don't have your textbook, I can go find some extras, or you just share with whoever's next to you.
I didn't bring my textbook.
I didn't bring it either.
I think I did.
Here you go. You guys
Oh,
share with her.
Sharon's Karen.
A few things I do want to go over before I forget. Just questions that I know you guys will have come test day, because your last day is practice, so it's a good chance you guys will be kind of leaving at different times because we're just practicing. So after your test, and I will see you guys on test day also, but after your test, you guys are testing on a Friday, you will receive your results most likely that evening, okay? Could be the following Monday. Once you've gotten your results, it takes sometimes 6 to 10 days to put you on the Board of Nursing. The Board of Nursing will not let me contact them about you until it has been 6 weeks. Okay, it used to be 4, they pushed it to 6. Okay, so what I tell you guys is if it's been 4 weeks, then you can reach out to me and I will reach out to them. Okay, if it's been 2 or 3 weeks and you know everybody else in your class is already on the board, if you guys are talking to each other about it, then go ahead and reach out to me. But if that's not the case, they will not answer me about a student until it's been 6 weeks. They will very rudely write back and reply this date, their test date does not.
Where do you look to see if you're on the boards or not?
So to see if you're on the board, it's very, very simple. You're just going to type into Google KBN, license lookup, license verification, anything like that. Just KBN license lookup, okay? Type it in Google. It's going to pop straight up. You just click on that first link, and then you'll just type in your name, your first and last name, verify you're not a robot, and search it, and then it will pop up a license number for you.
Question: if you already previously had a license, do you just keep the same number?
I'm pretty sure.
I don't know if the number is the same or not. It may be, but you'll still pop up because it still has your new issue date and your new expiration date. So you'll
So-
still know if it's your new one or your old
So
one.
we can just go to KBN and
You can just go to KBN, yes.
So say like after this class we wanted to get a job as a CNA or whatever,
Mhm.
can we go ahead and do that without being on the boards, or do we have to wait till we're on the boards?
It just depends on your employer. A lot of employers will go ahead and hire you
Okay.
before you even pass your test, just on the basis that you're going to be taking your test. Most employers, you can say, I've passed my test, here's the email, because you're going to get a confirmation email saying, like, you passed, congratulations. You can forward them that. Some of them want your license number before they'll let you start.
Okay.
Some of them, because you should technically be training and on orientation anyways for a few weeks, will not care about your license number. It just depends.
Gotcha.
So
Okay.
your license expires, how do you renew it?
Okay, that's a really good question too. So you guys have to renew your SRNA license every 2 years. Nurses, our license expire in October. Your guys's will expire December. Okay, so every 2 years, December. So it's always the same month. You just know it's coming up. And if you work somewhere, if you're working in a hospital or a nursing home, you'll be getting a million emails, and your administration will be saying, make sure you guys are renewing it. They'll make sure you know. You have to work at least 8 hours in 2 years to renew your license. As long as you've done that, that's the only qualification. And you can get on KBN. You'll have your own username on there that you'll get whenever you get your license number. So you just log right in and renew them. It's very easy.
And then when it comes to like a different state, do you have to pay for a license in a different state, or does it work in?
You should be able to transfer. I think it's like a low cost, depending on where you're doing it. Again, it's very easy to do through the KBN website.
Okay.
And if you are going through an employer, sometimes they'll do it for you.
Okay.
It just depends.
Can you get a multi-state license?
I don't.
you can transfer
You
your
can
license.
apply for reciprocity in the tri-state area. That's what they did to me
Nice.
last time.
Ohio,
Yeah, like
Kentucky,
Ohio.
West Virginia.
Okay.
So what's it
Because
called?
That would make sense with St.
Guys,
Guys, I do have a license number.
But it's expired right now.
Yeah.
Very.
Yeah, I can tell you, there's like 400 Amber Stevenses.
The KBN is
Got
pretty.
excited, sorry guys.
It's pretty user friendly. It's not easy to contact anyone at the Board of Nursing, but it is pretty user friendly to use their website and figure all of that out. You guys are more than welcome to use me as a reference if you want to for any job. If you need a reference, I don't care to do that for you. But I do a whole lot of them. They always come to my email. So if you want me to put something specific on there, like if you want me to be your friend from 5 years ago, you need to make sure I know that, okay? Or else I'm
Fresh
just,
from 5 years
or else I'm
ago.
just gonna do it as your instructor, okay?
She's
which,
my bud.
Which usually they like, and King's Daughters, I do it for King's Daughters all the time. I just put I was your instructor. I won't even remember you, and I say you're a great student and you helped everybody. And
You're a
I-
great student.
I'm gonna text you and be like,
She just wants
we used to work together.
She does. She
You're
just
my
wants
instructor
everybody
and
to
we
do
work
good.
together.
I want you guys to do good. There are some classes that I don't say that to, that I kind of single people out and say, like, if you need a reference.
She doesn't tell the whole class. It's like,
Yeah.
can you stay a few minutes later? I need
Yeah.
to talk to you.
Yeah. I don't always tell the whole class that, but the only time I don't is when I have those really awful classes that won't speak and just, classes like that I think you got no business. I would have a problem being, for any of you, okay? So my school email, you guys can use that on your job applications, and I will fill it out if they send it to that email. Okay. And because usually it's not a phone call anymore. It's King's Daughters in most nursing homes. It's just a questionnaire that takes me like 10 minutes. And we do that.
Where's my direction go?
Word, what?
I love that. That was awesome.
What did he say?
She's not one direction, she's no direction.
Oh, guys. Oh, my goodness. Now, think about this. When you won't want somebody to say something about you like that, because I know
When you
I'm...
first start, like, if you start at, like, a hospital as, like, a nurse aide,
Mhm.
like, how much training do they do with you?
That's a really good question.
They're gonna work your guts out.
Cause like I don't like I'm scared that I'm gonna like start at a hospital and then they're just gonna throw me in and expect me to know what I'm
No.
doing.
Like if you're a
Straight
King's
to the
Daughters, you
wolves.
get like a week of training, and then you have all these videos that you have to watch too before you're allowed to ever do anything.
You'll shadow with a PCT
And
for
yeah,
a while.
they shadow you for, I think, 2 weeks before you get put into the actual.
Unless
No,
you
doesn't a
You
PCT
should.
take a lot more requirements?
Psych
than
ward was
S-
did
it
not give us
doesn't?
that much.
Where was I seeing
Like,
something?
so unless you want your
A
PCT.
PCT is the same thing.
You have to
as-
know phlebotomy though, don't you? Or- no? Okay.
A
I was thinking-
PCT is an SRNA, that's just what they call them at King's Daughters. Now, we teach an advanced nurse aid class, which is great if you're going in the nursing program, if you want credits and all that stuff. But it's not something I'd ever sell to you because advanced nurse aid is just what they teach you to do as a PCT at King's Daughters. That's just pulling IVs, pulling Foley's, a little bit of wound care. So you guys right now, as soon as you finish this class, can work at King's Daughters as a
And do
PCT,
the same thing.
and they're going to train you to do it there.
Do it all.
So I will tell you, I think starting pay at King's Daughters right now is around 15. I know Wortland is nursing home is at 18.
Woodland's at 18 to 24.
Woodland's 18 to 24.
Cabell is also 18.
Cabell's 18.
Get
King's
you
Daughters is
bread.
always going to be one of the lowest paying. They just. I can't tell you at the hospital. I can't tell you if they suck. I've never worked there. I don't know. I worked at Bellefonte and SOMC. I've never worked at King's Daughters.
I
They
have a few
suck.
friends that are
Rain buddy.
PCTs.
I wanna
work
go
in
to Cabell
nuclear
so bad. If I go to
medicine,
any
and
hospital, I wanna
so
go to Cabell.
dirty.
And I hear good things.
Like there's cockroaches.
Cabell, you can pick your
No,
floor.
that's ICU.
Yeah, and PCT at King's Daughters, you're doing a lot of one-on-ones with
Yeah.
people who try to kill
Because my
themselves.
friend was like, oh yeah, I just hot shot
But
cockroaches
yeah, at
all
King's
the
Daughters, they
time.
just stick you somewhere wherever is available, but Cabell, you can pick the floor that's open.
How far is Cabell from
You're,
here?
30
it,
minutes
Depending
from
on
my
how
house.
fast
Worth
you
the drive.
drive.
It is.
it is. You think about it. You're gonna be
I
making
get there in
$3
15
$3
minutes
more
from my
dollars on the
house, but I
hour.
also have a lead foot.
So it depends on how fast you booking it.
See, I be busting 90 through
Depends.
South Carolina.
Me too.
Are you busting
I'll go
90?
up to- I'll go up to one
The
guy.
money's in nursing homes, you guys. A lot of people prefer hospitals. You just kind of got to get in there and see what you like better.
Well,
I will
depends
tell
on
you,
what you're
usually
doing.
the money's at the nursing homes, but
Heck yeah, it
it's
is.
just whatever you like.
I know that some nursing homes do like sign-on bonuses. We were talking about it earlier.
Yeah. Yes.
But how long do you have to work there before you get that?
You
That would
get it in
depend.
monthly checks, I think.
Yeah.
I think
It's
it
always
goes
different.
into-
There's
yeah.
Depends.
There's
always
two
different
ways you can get it at
stipulations.
Woodland.
Are there?
You can get it in a lump sum, but it takes longer to get it, or you can get it monthly checks, but you have to work there for a year or else you have to pay that back.
Oh.
Yeah.
Which any
Anywhere
place
you
offering
sign,
sign-on bonus
yeah.
is gonna be different.
Yeah, that's
Yeah.
why I didn't go through this class in Kingsbrook. I had the job and everything, and I was like, I don't know if I want to be signed to a lease for a year.
Yeah, you have to sign a 1-year contract with King's Daughters.
Yeah, but you get childcare with King's Daughters too.
Yeah, but they're.
Well, that could have been a benefit.
I don't trust them people with my kids.
I didn't know at the
Literally.
time.
My cousin's wife, they have childcare for Kingsbrook because she works there.
So,
Any, not say that to your
any
kid.
questions that you guys ever have, I'm always available to you after the class is over. You guys can always reach out to me. I'll still help you guys with anything. You just let me know. But I do want to make it clear, I cannot contact the board for you until it
6
don't
weeks.
even tell me until 4 weeks. You can
Oh.
tell me 6 weeks, I'll tell them. Okay. Any other questions about that?
No.
No? Okay. Let's go to,
coming your way for
you're
the
gonna flip to
textbook.
the very last page on this packet we've been working on, the denture care packet. It starts with denture care.
To the very last page.
The very last page. And in your book, you're gonna be flipping to we're going to, let me see.
Page 449.
It should be.
Continue
Somewhere over
document
there.
collection.
Ooh, I like 510. Look, it teaches you sign languages in the book, this book.
Oh!
Yeah, I knew very little because I had an instructor.
Shane, I don't think you'll need that one in the hospital.
You use a lot
Yeah.
Page 635.
Oh.
So I wrote this study guide when we were still on the 8th edition book. So some pages it will say like, sometimes I have both on there, and then sometimes it may say like page 638, box 52. The boxes are the same is what I'm getting at, okay? If there's two different page numbers and you have the newest book, you're going with the second one. But the boxes are always the same. So if it says go to box 2-1, regardless if you have the 8th or 9th edition, it's still going to be box 2-1. You're just going to have to look for it.
Choking Charlie.
Girl, you got us on Choking Charlie.
Alright, the first thing we're going to talk about is hemorrhaging. Okay, so bleeding. So obviously there's internal and external bleeding. Internal bleeding, there's not much we're going to do except, contact EMS, send them out, do whatever, okay? If it is external bleeding, okay, if we're hemorrhaging and it's external bleeding, I'm on 635 here. The very first thing I'm going to do is hold direct pressure to that wound. So that's going to look different depending on where I'm at. If I'm in a nursing home, I'm going to grab just clean gauze. If I'm in Taco Bell, I'm going to grab clean napkins. If I'm on a surgical unit where we're expecting that people could hemorrhage, then I'm going to have a hemorrhage kit and I've got sterile gauze. Okay? So just the cleanest thing that I can put as a barrier between myself and my patient. Okay? I want it sterile if I have that, but it's just whatever I have. Okay? So I'm going to hold hard, direct pressure. When my patient is hemorrhaging, first of all, I want to get them, it is going to be an emergency situation. So if this is a nursing home patient, I'm calling 911 to send them out. If this is in a hospital, then we're calling backup, and I've got other people coming in. Just like when we're doing CPR, and I told you guys that in hospitals the nurses are taking turns and going in a line doing compressions. Same here when we're holding pressure on a wound that is bleeding for an extensive period of time, because you can't hold effective pressure for that long. You're going to wear out, okay? So when I have a patient bleeding, if they're bleeding from a vein versus an artery, I'm going to be able to tell, because a vein is going to be a dark red color. Okay, so like a dark red blood, and it's going to just be a slow, steady stream that doesn't stop. Okay, that's a vein. When my patient's bleeding from an artery, it's going to go in spurts.
It's gonna gush.
It's going to be spurts like a heartbeat, and it's bright red blood. So that's the difference between a vein and an artery. A capillary is really no issue. A capillary is like when you nick yourself shaving. Okay, it's going to trickle for a long time and be annoying, but we can put a Band-Aid on. Okay, so I'm holding hard direct pressure to the wound. If that does not stop the bleeding, I can then move to the artery above the wound. So you guys don't have to learn every artery for this class. Really the only ones I need you to know are, this is my so this is radial, this is
Brachial.
Anyone know what this one would be?
Rotted.
What about on your foot? Anyone know that one? That's pedal, where you would take a pedal pulse. And then popliteal is behind your knee, but you don't need to write that one. Still known fact, popliteal, I like that word. So, if, let's say somebody cut their arm all up, okay, in an accident or whatever it might be, I'm holding direct pressure to their arm. That's not stopping it. Now I'm going to move to the artery above, but I'm first trying direct pressure. Okay. When someone is hemorrhaging, they're going to be freezing cold from all that blood loss, so I want to keep them warm. So the ambulances are going to have their heat cranked up in there. If they're in a hospital room, we've got the heat cranked up. I've got them covered in blankets and lying flat. I want them lying flat, if I didn't say that. They're also going to be very thirsty. They cannot have anything to drink until the bleeding has completely stopped. Okay, so they cannot have any water, nothing. So keep them flat, cover them in blankets, nothing to drink. What's that abbreviation for nothing to drink?
NPO.
NPO. They're NPO. Nothing by mouth. So remember, I want a sterile dressing. If I don't have it, then I'm going to grab whatever I can. Okay. Any questions about bleeding? The other thing I can do if the bleeding is not stopping is I can lift whatever extremity it is above the level of their heart and see if that helps too. Bleeding can go on. If it's like it just depends on if it's a car accident and I've got internal hemorrhage, we're probably rushing trying to get them into surgery, right? Sometimes it's from a surgical. So, like I worked cath lab or heart care, and we took care of patients straight out of cath lab all the time. We would do a lot of caths through their femoral artery, so like right here on your hip, and those were known to bleed. So it wasn't rare that we would have somebody come back in hemorrhage from that spot where they did the cath, and sometimes it would be 2 hours that we were just holding pressure. Okay, so those are the cases where it's going to take more than one nurse to stand in there and hold pressure for 2 hours. Okay, so it can go on for a while if it's not something we're taking them to surgery to stop.
So
Make
when are
sense,
you
everybody?
tourniqueting?
You would tourniquet if it were a situation like I've only got one person here and I'm not holding effective pressure and we're trying to get them to the hospital. I'm going to wrap a tourniquet. That would be that kind of situation. Make sense, everybody? Everyone good on hemorrhaging? Okay, let's talk about fainting. They talk about fainting a lot in phlebotomy because it's very common with blood draws.
You lie them down.
You lie them down. So fainting there's several signs of fainting. The number one sign that someone's going to faint is they're going to tell you, I'm going to faint. Okay? Most of the time you can feel it coming on. So if it's a patient that you're going to draw blood on them and they tell you, I'm feeling woozy, I feel like I'm going to pass out as soon as you bring that needle out, they probably are. Wound care can make people faint sometimes just from the look and the pain of it. Patients can faint. And then like sports teams and things like that, you got kids out there practicing, they've been sitting playing Roblox for 10 hours straight and now they're out in the hot, sun running, they feel like they're gonna faint, and it's common for that. So signs that someone's gonna faint, they're gonna tell you, they're gonna be pale, diaphoretic, remember that word, they're sweaty, they're gonna start to get dizzy, and then usually their vision's gonna start going, so they're gonna start seeing black. So pale, diaphoretic, dizzy. If somebody tells me that they're going to faint, so if this is like a little kid out playing sports, or this is somebody sitting in my chair getting ready to get blood drawn, if they're sitting up and they can feel that they're going to faint, I'm going to have them bend forward and put their head between their knees. And that's the recovery position that we'll usually have them come to, and they'll be okay. So bent forward, head between knees is your recovery position. Anyone ever seen that? Like people on the sidelines bent over
Head
like
between
that?
their legs.
That's a head between their legs, yeah.
What's that stuff they put underneath their nose too?
Ammonia.
Smelling salts.
Smelling salts. If the person is lying down, so if we have a patient that tells us, hey, if you draw my blood, I'm going to faint, then we can say, cool, let's put you in bed, and we'll do it in the bed. So if I've got a patient lying down already, I'm going to draw their blood. I still don't want them to faint, even though they're already lying down. And we can lift their legs above the level of their head. So we can just, crank the bed up and put their legs above their head.
Or put them in a reclined position. That's what it says in the phlebotomy book. Put them in a reclined position too.
Like legs up.
I don't know what I meant, like reclined position. I was like, just like put them in a chair, like what?
Laying back?
Yeah.
Oh, well, I guess that'd be the same as laying in bed.
I faint when I get my blood drawn, and they I tell them every time before I even get stuck. I'm like, I'm gonna faint whenever I see the blood coming out, and they're just like, okay, and they don't do anything. They just have me stay in the chair.
A lot of times they don't believe you.
Yeah, and then I faint, and they're like, oh.
Because I know sometimes, if you have, cancer or something, they'll be like, they'll just keep the thing there. So if you faint, you fall forward, and they just it catches you.
So, if your patient does faint, it's not an emergency situation. We don't have to call for anybody. We're not stressed about it, especially if they're in a bed. If they're sitting in a chair and they faint, we're just going to ease them to the floor. You can use like the ammonia sniffing salt things, but you really don't have to. They're going to come back to. You just kind of stay with them. They'll wake back up, and then we just want them to stay with us. We just want to stay with them at least 5 minutes after to make sure they're good and okay. Like, I wouldn't want them to pop right back up and go drive their car. Or I wouldn't want my elderly patient to pop right back up and,
Grandma hit the gas.
waddle down the road.
That's what they do to me. They just send me on my way after it happens.
You want to stay with them at least 5 minutes and make sure they're good.
Yeah, after I have phlebotomy done where I have too much iron in my body, they always tell me I'm okay, because they're like, you need to sit down for 10 minutes. I was like, I'm okay. I know my body.
Yeah, that's why when you get your blood drawn for blood donation, they have you lay down.
Yeah.
It's just in case you're fainting.
Yeah. It just makes it easier, because if you're laying down, then you just take a little nap and you'll be back.
Well, they take a half a liter of blood out of me each time, so that's.
And you only got 5 liters of blood in your body, so.
Yeah.
They take a half a liter out.
I think girls have less. I think they have 4, but.
So.
I've never had donated blood before.
I have many a times I've had
can't,
transfusions.
'cause
Well,
It
actually,
causes
you
antibodies
could
really
lay
bad.
you down, but.
Well, I mean, up until a couple months ago, I didn't weigh enough to donate blood. They always told me I went one time
Get
to
out of
donate,
here,
and they were like, you don't weigh enough.
I know, I would give blood, but I have too many medical problems to give blood.
I give blood about every 2 or 3 months.
Are you allowed to?
You know you can get paid to donate plasma.
I only asked that because you got rheumatoid arthritis, and I'm like, are you even allowed
It's
to?
an autoimmune disease, but it's not catchable. I mean, it's not like even if you touched my blood.
Well, I was
can't
just like
get
thinking
it.
it'd affect the white blood cell count and everything.
Oh,
I'm not
can.
sure, why can a diabetic not, because of
Because
Whether
I'm not allowed
glucose
to have
is,
my blood drawn because I have such
elevated
a high white blood
down.
cell
I've never been able to give blood, so.
He's like, I don't know, but I do.
I put down
YOLO.
on the questionnaire
Because I'm
that I
severely
have,
anemic.
You know, rheumatoid arthritis.
Yeah, so we don't want yours. Well, if you can donate blood, you guys, it's a good thing to do.
it is.
I'll say that. It's
Give it all.
definitely
Give the whole 5
needed.
liters worth.
All right, let's talk about seizures.
There's
You
a lot
really
of
want this
different types
guy's
of
plasma
seizures.
out here.
Yes, so there are so many different types of seizures. All seizure disorders are very different, very specific, okay? So these are just 3. A lot of seizures are going to fall into these main categories, okay? So let's talk about, and we are on page, if you're wanting to look, 638. Also, seizures are very, very common. If you're working in a nursing home in a hospital, you are very likely going to have at least one patient with some type of seizure disorder. So, the first one we're going to talk about, this is called a generalized absence or a petit mal seizure. These are, the main thing you need to know here is that you do lose consciousness. Okay, so you are going to lose consciousness, but they only last a few seconds. Okay, there's no twitching involved, there's no jerking involved. So for the most part, they are not dangerous. Okay, so it would be, but you do lose consciousness. So it would be like I'm sitting here lecturing you, and then for 5 seconds, I just kind of stare off, and then I kind of come back to. Now you lose consciousness, so I'm aware that I was just kind of out of it for a second, but it was only 5 seconds ago, so I still know what's going on. You know what I mean? You kind of just like snap back to it. So that's not dangerous at all unless I happen to be driving or cooking or walking down the stairs. You know what I mean? So if I have a generalized absence petit mal seizure disorder, if I'm having them once a year, I'm probably good. If I'm having them 10 times a day, that's going to cause some issues in my life, right? Because you don't know what you're going to be doing. Okay, so main thing there, petit mal seizures, you do lose consciousness. They only last a few seconds. There's no first aid necessary unless, of course, you fall down the stairs because you just happen to be, usually there's no treatment or no first aid necessary. So that's a petit mal. They're very similar to febrile seizures that kids have sometimes. Not the same, but they're kind of similar. The next one is a partial seizure. This is only one part of the brain is involved. The main thing here is that you do not lose consciousness. Okay, so you are still very aware of what's happening. You can have like the jerking, twitching movements, but they're usually only to like one extremity. And then you do have hearing or vision problems with them. So it'd be like, you know, you're kind of just living your life and now you're having some muscle spasms that you can't help and you can't hear anything, and they can last 20, 30, 2 minutes, 20, 30 seconds, 2 minutes sometimes. Okay? So because you don't lose consciousness, they are not necessarily dangerous because I can stop myself from doing whatever I might have been doing. Okay, and there's usually no first aid necessary. So you do not lose consciousness with a partial seizure. That's the main thing you need to know. Partial, you don't lose consciousness. Petit mal, you do lose consciousness. Okay, everyone got that? Know the difference? The last one that we're going to talk about, these are the big bad ones that you think of when you picture somebody having a seizure. These are generalized tonic-clonic or grand mal seizures. Okay. These are the ones that can be very dangerous. They come on quick. Now, the good thing about a grand mal or a tonic-clonic seizure is that patients typically, not always, but typically have some kind of aura before they have the seizure. Okay, so an aura can be that they smell cigarette smoke. I had one patient one time that said she tasted metal. It's anything that happens before every seizure and it clues your patient in that they're going to have a seizure. So it could be something they hear, something they taste, but it's some kind of sign. I've also heard a lot of people say they have auras before they get a bad migraine or something like that. So
That's definitely true.
Yep, so same kind of thing. They have like a signal that it's coming before they have the seizure, and if they do, that's great, because then I can prepare them. So if my patient tells me, you know, I'm seeing little blue lights, I think I'm going to have a seizure, I can very quickly get her into bed. If I don't have a bed, I can quickly get her on the floor, get her head in my lap, and be prepared for her to have one. Okay. If they don't have an aura and it happens quickly, typically there's injuries involved, because these are the kind of patients that'll just be walking down the hall and then drop very quickly, bust their head, and go into a seizure. Okay. It usually happens really fast like that.
Can't you seize during your sleep too?
Yeah,
Probably.
my son has
Sure you
nocturnal seizures.
Steve.
So is like
It's a
the
different
one you're
kid,
talking
not
about
the
right now, is that
autistic
like
one.
people with epilepsy and stuff?
That'd be rough if you also had.
No, he had brain surgery at 5 for it.
Oh.
So when you have a grand mal seizure, these are the patients that are having contractions everywhere, okay? They're having jerking movements to all extremities. Usually they're going to have an incontinent episode, incontinent bowel and bladder, when they have one. The main thing that we're focused on is their safety and preventing them from hurting themselves, okay? So if they're not in bed, if my patient falls to the floor, or if I have to lower them to the floor, the very first thing I'd want to do is move all furniture from around them. So I would scooch the tables away from them. I'm going to yell at somebody to go get me pillows, as many as they can get, to put under their extremities and to put under their head. In the meantime, while I'm waiting on pillows, if I have nothing to put under their head, I'm going to sit in the floor, crisscross applesauce, and I want their head in my lap.
How do you
Okay?
stop them from biting, like biting with their tongue?
You don't anymore.
Oh, you can't put like wooden.
No, they can choke on it.
Mm.
You just gotta let them bite their tongue.
So, main thing is quickly get in the floor with them and protect their head, okay? And it can hurt, okay? Because those jerking movements are hard, so they can really kind of bruise you up, you know, thrashing into your lap like that, but better that than busting their head against the ground, right? So you quickly want to get underneath them. Then we can have someone bring pillows and protect their extremities, and I can put those pillows under their head after that. After they have the seizure, that's when they go into that like clonic phase. So after they have the seizure, that's when I'm going to put them on their left side in recovery position. They're most likely going to be sick. They're going to vomit. They're going to have a terrible headache. They are going to feel like they've been hit by a bus because they're so sore from all that contracting. And they're pretty much down for the count in bed the next 12 to 24 hours. Just exhausted, just sleeping. It really just kind of wipes people out. So, main care for a patient when they're having the seizure, during the seizure, is A, safety, and then B, I want to look at the clock when the seizure starts. The more specific I can be, the better. So if I can say it's 1:35 and 13 seconds, that's great. If it's just 1:35, that's fine too. And then I need to know what time it stopped. Because if that seizure goes more than 5 minutes, that is going to be an emergency situation, and I've got to get them
Is that
shipped
when it
out.
started?
Give them their
Causing brain damage?
Voltico up the nose.
Up the nose again.
What does that do if it goes on for more than 5 minutes? Can it like
It can cause a lot of
brain
brain
damage.
Yeah, neurological
that's wrong
damage.
term,
But they-
not fried,
So, we were speaking of Narcan earlier. They now have like Voltico that comes and it looks like Narcan, and you just shoot it up their nose, and it should calm them down.
I knew a girl in high school who had like chronic seizures, and she had like a rod in her chest, and you'd like swipe like a thing and like zap her, like keep zapping her, and it would eventually bring her to. But
They have things in your brain now too that you can do something on their head, and it will stop it.
This one girl on this show, it was about Tourette's, and she had seizures, and they was trying to put a thing inside of her brain to help her with it.
Yep. Some patients have those. That's more for patients that are having several a day. So if you've got a patient that's having a seizure a month or something like that, they probably don't have that. So you just got to kind of do everything else and be with them. You can't stop it. Any questions about seizures? Everyone feel good with that?
man, look at that burn. That's gnarly.
Okay. That is a bad burn. Okay, let's look at, we're just about done here, you guys. Let's look at chapter, we're going to the respiratory chapter, is page 401. There's a few definitions I want you guys to know here. Most of them you guys should already know. That's fine, you don't need to write them down. If you don't know them, please write them down. First of all, what is the term for a fast heartbeat?
tachycardia.
Tachycardia. What's a slow heartbeat?
Bradycardia.
What is a fast respirations?
Hyperventilation.
Tachy what? What's breathing? Penia.
Penia.
Tachypenia.
I was trying to think of how to say that.
So slow respirations would be what?
Bradypenia.
Bradypenia. Okay. High blood pressure would be.
Hypertension.
Low blood pressure would be.
Hypertension.
Okay. The few terms that I want you guys to write down here. Oxygen concentration. That's, remember, the same as oxygen saturation. How are we measuring that? What are we using? The finger thing, what's that called?
Pulse ox.
Pulse oximeter. So an oxygen concentration or an oxygen saturation or O2 sat, all the same thing. That is the percent of hemoglobin containing blood. Percent of hemoglobin containing blood. There's no way to manually measure that, obviously. We can only do that with a pulse ox. Or nowadays an iPhone or an Apple Watch or whatever you got. What is a normal O2 sat?
90.
95 to 100.
95, yeah.
Can you not do blood gases no more for that? I mean, not, and of course, not in a nursing home, but
Blood gases
like if it
suck.
in the hospital, they can just okay. Because I've had a lot of blood
Blood
gases in
gases
my life.
suck.
So normal
Terrible,
would be
they hurt.
90 to 100%. I want it above 95. So 90 to 100% is normal. I want it above 95. Anything below 90, I'm going to treat. And how am I going to treat it?
Nasal cannula.
With oxygen via a nasal cannula.
If they have like COPD or like they've smoked for a long time, that's gonna be lower, right?
It's going to be
Is there a
lower.
certain range?
88.
Mhm.
88's about normal if I've got a COPD patient that's been living with it, and I'm not gonna put oxygen on them with 88, probably not until they get, it's really very dependent. But I've had them live kind of 86, 87% range without oxygen.
There
What if
probably is not
they're-
much you have not seen.
What if they're like on oxygen already and it's low? Like, is
We're
that-
gonna crank the oxygen up.
Crank it up, okay.
Yeah, then we're gonna crank the oxygen up.
You can breathe.
Alright guys, so what you're normally gonna see, we've got O2, so that's oxygen, 2 liters. Okay. So it's normally be a big long bunch of letters, but very easy. Oxygen
Nasal cannula.
at 2 liters. That's what we're gonna run the oxygen at. Be a nasal cannula.
As
This
needed.
PR means what?
As needed.
As needed for an O2 sat below 90. That's above, isn't it? Yeah. Below 90. Okay. So, another term on these definitions is cyanosis. A lot of times you'll hear the nurse say that the patient looks cyanotic. Cyanosis is just a bluish color to the skin and lips, mucous membranes. And cyanosis is an indicator that what?
They're not getting enough oxygen.
Their oxygen's low.
They got a lack of.
My youngest little boy had done that many a times in the NICU, and they had to bag him, and that was the scariest thing in my whole entire life. I was at dialysis because he was born at UK. I was at dialysis right down the road, and they called me, and I was like, "You better take me off this machine right now. I'm going to the hospital."
Taking the machine with.
Yeah.
Another one that I want you guys to know, orthopnea, just because this is pretty common with geriatric patients. These are patients that are breathing comfortably only when sitting. So that orthopnic position, we often see elderly patients. It doesn't have to be an elderly patient, but it happens a lot. And they live in their recliner, so they never lay down in bed. They say that when they lay down, it feels like they're smothering, like they can't breathe.
Me and Karen had a lady like that the other day.
Yeah,
They said she sleeps in a recliner and everything.
Yeah, to even get into bed kind of scares them, because if they lay back any, they feel like they're smothering. So the orthopnic position is sitting up and kind of lean forward like this on a table. You see that a lot with dying patients that are really short of breath and feel like they can't breathe. They'll kind of lean forward and sit up like that. So orthopnea, that's just your patients that are sitting up and can't breathe otherwise.
It's on my 600-pound life too. So you'll see that on my 600-pound life too.
There's so many things that can affect your breathing, like even your sinuses can affect it.
Yep.
Sometimes when my sinuses stop, and I feel like I can't breathe.
Yeah.
I mean, you gotta do what you gotta do.
Okay.
Sorry, people.
That was great.
Cheyenne Stokes respirations. This is a really important one, okay? This is, you can see Cheyenne Stokes respirations in more than just dying patients, but it is very, very common in our actively dying patients, okay? So what happens is, I have patients with going back and forth between slow, shallow respirations, maybe 4 a minute, okay, so super slow, split up between a period of apnea. Apnea is what? Think about
Like where
slow,
they stop breathing?
Stop.
apnea is when it stops. So think about like sleep apnea. Those are patients that quit breathing in their
Or they
sleep.
go,
Yeah, and they
gasp
wake
for
up.
air.
Yes. So I have patients that breathe very slow, maybe 4 a minute, then stop. They have a period of apnea for 20 seconds. So I've got families sitting here with their dying resident, and what do they think just happened?
They think they died.
Yeah.
They think they died because they haven't breathed for 20 seconds, and then they have a period of yes, and very fast, deep
Gasping.
respirations. So then they're, you know, just completely freaked out that they just died. Now they're breathing again, and it's very scary. It can be scary for aides if they don't know what to expect. So Cheyenne Stokes respirations is one of those patterns that we need to be telling family members about, and just kind of educating them pretty much every day until that patient passes. We're just going to kind of tell them, hey, remember, it's very normal that they may stop breathing for 10, 20 seconds. You can come get me anytime if you're nervous, but usually unless it's been 30 seconds, we don't think it's happened yet. Okay, come get me anytime you want, but it's normal that they'll stop. Okay, and same for you guys, because if you're in there staring at your patient, you just walked in and you haven't seen them breathe 20 seconds and then they gasp, it's kind of scary. Okay, so it's just a pattern you need to be aware of. And then of course, a tracheostomy, we'll just make that the last term just because that's something you guys will see very often. That is just a surgically created opening in the trachea. Okay, so those are trach patients.
We have a girl that comes in Olive Garden and she has a trach and she can't like eat foods, so she spits them in our cups and leaves them at our tables. It is awful.
Still likes to taste them.
I told everybody, I said, you put that girl at my table again, I understand she can't help it, but I'm not cleaning up her cups of spit up. No.
Yeah, I get it, but you'd think she would like throw
Bring a
them away.
blue bag, maybe.
Yeah, bring a
spit
bag.
in
Bring your
bag,
MSS bag.
something. But no, she she just leaves them on our tables, and we have to clean them up after her.
What's the difference?
They make us put gloves on, I will say, but yeah, it's.
I would put gloves on.
Yes, ma'am. Put you some gloves on.
So what's the difference between a tracheostomy and a tracheotomy?
Taking your trach out.
Tracheotomy is when they take it out, and then tracheostomy is when they do the incision and put a trach in. Okay.
There's sometimes people that have like a hole in their neck and they talk with like a thing up to like their.
No, they don't have to use one of those.
They don't have to. There's different types depending on, honestly, a bunch of stuff. And these patients, you guys, usually your nurse is going in, changing that trach, suctioning that trach. Sometimes aides are trained to do it also, depending.
Get a straw.
Okay.
No, you're not getting a straw.
I don't want my food to come back up.
Only Jane.
I know, right?
We're getting, we just got this huge grant, and I got to like pick all this really cool stuff that I wanted to buy for class. And one of the things that I got is a COPD. It just made me think about it. But one of the things I got is a COPD. I got a Alzheimer's, what's the word I'm trying to think of? Makes you feel like you have Alzheimer's. What's
Dementia simulation?
simulation, that's the
Oh.
word. Yeah, so I got this COPD simulator, and it looks really cool, but it's a really tight vest you have to put on your chest, and it's heavy, and you have to tie it really tight, and then it comes with a straw, and you
comes with
have
a
to
straw.
breathe through that straw, and you have to walk around the classroom with that really tight thing on your chest
To see
and
how they
breathe-
feel.
to see how it feels to live with COPD.
I feel
I
like
thought
it
that's
would be
so
like
cool.
me being pregnant again.
They